Can start now.
Good evening, all. In recent past, doctors became soft target and patients became consumers. The human touch, empathy, art of healing is now lost to science and evidence-based protocols. This drowns the clinician, a doctor, in a sea of information. Today's doctor needs a curated path from this haphazard information, which he can mend with his experience and use for the patient who is in front of him. In Journal Journey, our effort is to present an article which is relevant, created by pure science, and gives valuable inputs which can be used in our day-to-day practice for a pediatrician of periphery. Welcome all the dignitaries once again, and may I request our star member of Raigad IIP, Dr. Swati Likhite, to take over.
Good evening and warm welcome to all the doctors.
Unmute yourself. Unmute
Doctor,
yourself.
unmute yourself.
I'm extremely sorry. I just start again. Good evening and warm welcome to all the doctors to our journal journey. Both the topics taken up today are indeed interesting. I invite our Maharashtra IP President, Dr. Hemant Gangolia, sir, for the opening remarks.
Thank you, madam. Good evening and namaste to all the respected dignitaries on the dais, and welcome all the viewers on the MahaIP YouTube channel for this Journal Journey episode. Yes, Journal Journey reminds of our journal club during our PG days, and reading the journal is an art. And we are today, this evening, we are extremely fortunate to have Dr. G.B. Basavaraja sir, past Honorary Secretary General as well as President of Bangalore Pediatric Society as a chief guest. We do have guest of honor, Professor Harish Pemde sir from Delhi. He is a president of AHA and past EB member, as well as in absentia, we have Dr. Jayan Joshi sir, who is EB, past EB member from Pune. And we have fantastic experts, Dr. Mohit Sahni and Dr. Vibhor Vorkar, as well as speakers, all both speakers, Dr. Kalpana Madam, Dr. Reminaka, as well as moderators, Dr. Chitra Kulkarni Madam and Dr. Swati Likhite. As well, I acknowledge the presence of Dr. Jitendra Gawane, President of Navi Mumbai, President of Navi Mumbai, as well as I see Dr. Renu Baralkar, Chairman of MahaIP Bhavan Committee, and all office bearers, our Dr. Pramod Wankhede sir, my Raigad IIP President, as well as my Secretary General Dr. Amol Pawar, and all the dignitaries on this dais. This journal journey, the journey of this journal journey started from district Raigad, and it went across the Maharashtra state this year. Last episode we were at Gujarat. This evening we are at Goa, and probably hope so next month we will be at another state. So we have made this journal journey from district across the state and going to national level. Thanks IIP Raigad to start this initiative things, and we are marching towards ahead. With this, wish each one, and let's listen what this journal article teaches us to do in our practice as a general pediatrician. Thank you very much.
Thank you so much, sir. Now, may I request Raigad IIB President, Dr. Pramod Wankhede, sir, to give his comments and welcome the guests.
Before Dr. Wankhede sir starts, I acknowledge the presence of my dear Dr. Samir Sadavarti, EB of MyIP. Please, Samir, welcome.
Thank you.
Yes, Wankhede sir.
Thank you, sir. Thank you, madam. And really delighted to see Dr. Samir and Dr. Jitendra Bhai, Jitu Bhai here on this board. Respected today's guest of honor, Dr. Jayant Joshi sir. Today's expert, Dr. Saini sir, Dr. Viborkar sir, another expert, and presenter, Dr. Kalpana and Dr. Rimeka, and our main driving force of this journal journey and guide and mentor, Dr. Niman Mohanty sir. Another driving force along with him, Dr. Chitra Kulkarni, Dr. Jay Bhandarkar, and Dr. Neha. And our dynamic president, MyIP, Dr. Gangulia sir, dynamic secretary Amol Pawar, and all the dignitaries on the board of the board. This is a relentless journey of journal journey. And the main driving force is, I have just explained, and different topics are discussed here, and we get some knowledge in addition, and we get some wisdom from our expert also. So I extend my best wishes to this journey, and I hope that this journey will a never-ending journey and go long last. Thank you very much. Thank you.
Thank you so much, sir. Now I take the privilege to introduce our today's chief guest, Honorable Intensivist. He is Dr. G.V. Basavaraja, sir, from Bangalore. He is past Honorary Secretary General of Central IIP. And I also request sir to say a few words.
Thank you so much, Dr. Swati Likete madam. So respected our Honorable President of MyIP, so who has been revolutionized the MyIP academics in the 2022, Dr. Hemant Gangulia sir. Of course, Secretary who has been activated the Maharashtra IIP in such a big way for last as a treasurer, now as a secretary. So you can say mitochondria of MyIP and going to be the national figure, that is Dr. Amol Pawarji, and president of our Raigad branch, Dr. Pramod Wankhede sir, and the national scientific convener of this program, Dr. Jayant Bhandarkar sir. First I met him in Alibag. So during that time, Dr. Jayant Bhandarkar sir, Dr. Chitra Kulkarni madam, and Dr. Swati madam, and Dr. Hemant Gangulia sir, and all, they were conceptualizing how to go about the academic. I was a witness to that. So you have made it more robust and more academic of Raigad branch. Of course, under the guidance of our Chandrasekhar Dabadkar, then past vice president of West Zone. To drive all these things, we require a youngster like Dr. Neha Singh madam. So really, you all really made the things engine to move in a very speed up like a bullet train. And today's guest of honor, Professor Harish Memde, and who has been a past joint secretary of a liaison at the central level IIP, and also a most active member of medical education and as well as adolescent. Jayant Joshi ji, my good friend, who has been closely working with the MyIP and at the national level in ID as well as in respiratory. Of course, Jitu is the one who has been very galvanized all these academics along with our Renu Borkar madam. And all the senior member who has been joined, today's moderator, the brain behind this journal ki baat, which has started in Central IIP, journal journey by Namin Mohanty sir, who is guiding force for all. This is any organization to grow. What is most important is evidence-based practice. Where the evidence comes through the journals. That is one of the things what Mohanty sir is really galvanized. Today's moderator is Dr. Swati Madam and Chitra Kulkarni Madam. Of course, the expert like Mohit Saini sir and Dr. Vibhav and the faculties, Dr. Kalpana Madam and Rimanka Madam and all other who have been joined here. Really, Maha-IAP and Raigad branch really done an amazing work in academic. This is what the academy requires, what the members of academy require, what is available in the latest thing. That is what the India, whole other states should look at Raigad and Maha-IAP. Take the academics to the nook and corner. This is the role model, the Raigad branch and Maha-IAP is a role model to the rest of the states. Thanks to all the office bearers, especially Hemant Gangolia and the Mercurial Mitochondrial Secretary, Dr. Ramulji and Pramod Wankade, sir. Thank you. Wish you all the best. Samir Sadavate, my good friend, who is always, when you talk about academics, Samir is always there, whether it is an intensive care, medical, legal, but his presence itself galvanizes the whole audience. Thank you, Samirji. Thank you all for this, inviting me.
Thank you,
Wish you
sir.
all the best. I'll seek your blessings for my future endeavor with all your things. Thank you once again for inviting me as a chief guest here. I am happy to be always work with Maha-IAP. In future also looks to be work with Maha-IAP and all the district branches. Thank you very much for inviting me.
Thank you so much for your very much kind words. Now I welcome today's guest of honor, Dr. Harish Pemde sir from Delhi. Sir is a past executive board member and national president of AHA. I request Dr. Harish sir to say few words.
You, Maharashtra IAP President Dr. Hemant Gangulia, Secretary Dr. Amol Pawar, and Convener Dr. Jay Bhandarkar, and IAP President, Secretary, and Treasurer from IAP Dr. Bankhare, Dr. More, Dr. Rajput, and people from friends from Goa, Dr. and Dr. Kalkhatkar, and our experts, Dr. Mohit Sahni, Dr. Borkar, Dr. Chitra, and Dr. Swati Likhite. It is wonderful to join IAP Raigad, IAP Maharashtra, and Dr. Davadkar's branch it is. And Dr. Davadkar made it very popular for parenting issues and working from a rural area. We all were witness to it. But this is a very, very innovative and really very contributing to all pediatricians, journal's journey. And I'm extremely happy to note this journey is moving from Maharashtra to Gujarat to Goa and other places and all these city branches. This is really innovative idea. I'm sure Dr. Hemant Gangulia, Dr. Amol Pawar and their team must have made this idea. And this must be taken to all parts of IAP also. And Dr. Basavaraj has spread this instruction of having one mitochondria in every branch. So this will be a very good thing for IAP to come. And friends, what I want, what I dream that IAP should become a very, very household name, very trusted and valuable name by all parents, all common people. And this is very much possible through programs like this Journal's Journey and through kind of a participatory leadership, through improving quality of care for common things like treating diarrhea, treating pneumonia, immunizations, and whatever we do, early childhood development care and adolescent care. All these things are very, very important. And these can make IAP a household name, so much so that every IAP member is trusted as the best doctor for neonates, children, and adolescents. So this is my dream, which I am working for. And I'm sure many people would like this to happen. And I seek support from all of you, not only in this election, but in future also. So thank you very much again for this wonderful program. And I am sure people will be with me and I will be with Dr. Basavaraja and Dr. Jayant Joshi in next years to come in the IAP movement. Thank you very much.
Thank you, Dr. Harish sir, for the information. As in Maha-IAP, we started an initiative, Dr. Ek Vicharu Ka, every Sunday program for parents regarding awareness of all the common illnesses in the as well as the developmental wise. As well, sir, we are translating all 105 guidelines in Marathi, and we have reached up to 37 guidelines, and we have had a very good team under the leadership of Dr. Narendra Naniyudekar, who is doing all this wonderful work of translations, and then we are circulating all this, and this can be seen on our MahaIP website, sir. So we started trying. Let us how we can reach to each household. Thank you very much.
I will also give you some more work. We have developed guidelines for parenting of adolescents.
Okay.
And we are going to release next
Yes.
month in our Asian Congress of Adolescents. It's in English. This will be available on app also. So you may very well help us in translate these guidelines into Marathi. And that also we can host on our app. So anyone can get it free of cost everywhere. So
Yes,
wonderful
Doctor.
activity you are doing.
Thank you.
I'll just share that with you and you can all help us in that. Thank you
Yes.
so much.
Dr. Chitra Kulkarni, Dr. Neha Singh are very active in adolescent medicine. So they will be translating all the things up.
Yes, sir. Yes,
Thank
sir.
Thank you so much, Dr. Harish Pemde, sir. Now I welcome our second guest of honor, respected academician from our state, Dr. Jayant Joshi, sir, from Pune. He is a past executive board member, and I request sir also to share a few words.
Thank you, Swati madam. It's been really a privilege and pleasure to be amongst the galaxy of speakers here. I see my good friend Dr. Basavaraj, Dr. Harish Pemde sir, and along with that, I see Jitendra also and Redu madam also. As usual, just a couple of days back, I had a fortune of attending a quiz which was superbly moderated by Dr. Jay Bhandarkar, and it was really a pleasure to be in, where we had even Dr. Baldev Prajapati sir joining with his words of wisdom. So all in all, it's really a proud feeling to be a part of such a vibrant branch, and it is great to see how Dr. Gangolia sir and Dr. Amol are executing it to perfection. This journal club, I still remember when we were residents, referring to a journal used to be a novel thing. And now we used to always wonder that what can be the source by which we can easily access them. And look, it has now really come up to our door, and literally with the press of a button, you can access all these things. So I think I must really admire the creativity of Dr. Hemant Gangolia. Dr. Jitendra himself is a teacher and a professor. So he will agree with me that these things are so important in kind of, updating us to our day-to-day knowledge. And I really feel it proud. I also have great pleasure in welcoming Samir, close friend, then Dr. Pramod Wankhede sir, everyone from Navi Mumbai branch, Dr. Jay, belated happy birthday wishes. And I hope you had a blast yesterday. So I think with all these words, I thank you once again. I sincerely look forward to getting support from you all in my endeavor of the vice presidential election. And I seek your support. And I will, of course, with this illustrious team, we would definitely do a lot of things. And with your association, we can do a lot of new projects and achievements. So kindly help me, kindly bless me with your vote and support. Thank you so much. And thank you, Amol and Dr. Gangolia sir, for the opportunity. Thank you so much.
Thank you so much, Jayant sir. Now let us start our scientific session for the day. Invite MahaIP State Convener, Dr. Jay Bhandarkar sir, to introduce our first expert, Dr. Mohit Sahani sir, and then the first speaker, Dr. Kalpana Gauns. So over to Dr. Jay.
Dr. Jay is not audible.
Jai sir, unmute
Jay
yourself.
sir, unmute करा.
ऑडिओ इश्यू झाला त्यांच्याकडे.
Volume मोठा करा काहीतरी.
हॅलो, येतोय आवाज?
Yes, yes.
येतोय. Yes.
Good evening, everybody. Thank you, Swati, for giving opportunity to talk in the journal club we started on Doctor's Day 1.5 years back. And another thing, before introducing Mohit Sahani sir, I'm thankful to Samir Sadawarte for the excellent help you throughout the year. I asked him, मुझे कोई senior neonatologist चाहिए other than state, so that he can be expert for this today's our article. So Dr. Mohit Sahani sir is Director of the Institute of Child Health and Nirmal Hospital, Private Hospital, Surat, and neonatal focus Eco Academy, Surat, India. He is the editor-in-chief of the Journal of Neonatology, India. President NNF Gujarat State of Branch 2021 and governing body member of NNF Western Zone 2017 and 18 and member of Neonatal COVID Task Force, Government of India. It is the editor of books of Point of Care, Neonatal Ultrasound Echo, and Neonatal Echo, Fetal Echo Make Easy. So I welcome sir, and at the outset I thank Mohit sir for his presence. Is a very important journal club, which is I am personally fond of. As a student, I attended a lot of, and we started it, and I hope so it will continue in future leaders of the central IP. And what I expect from central IP, let us speak, because future leaders are here. We should have, when people give the reference of AAP, this American Academy in this PATs of Arabica, why not India come with its own guidelines and at hand should be available so that I can show to the patient? Yes. So for example, I want to do some test, it is indicated, so that I can give the reference from IIP itself, not referring other books. So I just welcome all you again for this wonderful session, and thanks, and again hand over to Swati for this further proceedings.
Sir, the first speaker, Dr. Kalpana. Put your video on, Dr. Kalpana.
Yeah, good evening, everyone.
Yeah.
I'm Dr. Kalpana Gauss. I'm pediatrician at Hospicio South Goa District Hospital, Margao, Goa. And I will be, I'm feeling very proud today to present this journal club. May I start my share screen sharing?
Yeah, please go ahead.
Thank you, ma'am. So today's article, we will be discussing implementation of nutrition care bundle and improved weight gain of extremely preterm infants to 36 weeks post-menstrual age, published in the Journal of Pediatrics, volume 241, February 2022. This study was a retrospective analysis of existing hospital data, which was collected prospectively over 3 different timelines, and different timelines had instituted different nurturing environments and feeding guidelines, which were followed as per the protocols prevailing during those different timelines in the hospital. The objective of this study was to evaluate the effect of a nutrition care bundle in improving growth in premature infants during neonatal hospitalization. The aims and hypotheses were developed and studied from the records. Hypothesis was the study tested that implementation of nutrition care bundle will be associated with improved weight gain of extremely low birth weight infants. This study examined 3 discrete time periods, also known as epochs in this study, in a single center, during which both the overall practice environment and nutrition-oriented initiatives underwent substantial changes targeted at improving the care of the patients. Postnatal growth of extremely preterm infants frequently lags behind the fetal in utero growth trajectories during neonatal hospitalization, leading to so-called extrauterine growth restriction. As postnatal growth and development of premature infants are complex processes, factors contributing to these are quality of growth before delivery, infections, and morbidities, and prerequisites of the feeding, that is, the provision of nutrition to preterm infants during neonatal hospitalization needs essential nutrient requirements and sufficient calories to support growth and development. Let's move to methods. The study design, it was a retrospective analysis of prospectively collected data for 584 surviving infants. It was based on 3 distinct epochs that represented evolution of nutrition practices at Women's and Infants Hospital of Rhode Island, USA. The hospital's institutional review board approved the study. This study participants consisted of extremely low birth weight infants with birth weight of less than equal to 1 kg and gestational age of 24 to 29 weeks. Both inborn and outborn infants were included. Exclusion criteria were infants who died during hospitalization or less than 24 weeks or more than equal to 30 weeks and whose hospitalization dates overlapped the study epochs. The primary unit of analysis was the infant, and the primary outcome was the change in infant's weight z-score between postnatal day 7 and 36 weeks postmenstrual age or hospital discharge, whichever came first. The time period was from July 3, 2005 and June 6, 2016. These three discrete epochs were defined as below. The epoch 1 was consisted of 266 infants. That is the first time period, July 3rd, 2006 to September 15, 2009. Here the feeding was initiated when child was clinically stable, advanced as tolerated. Human milk or premature infant formula was fortified from 20 to 24 kilocal per ounce, and enteral feeding should have reached by 100 ml per kg per day, means they started a little later. And patients were cared in an open NICU bay settings. The epoch 2 consisted of 188 infants from September 16 to 2009 to July 2nd, 2013. Here, the main change was the care was shifted from open bay setting to a single family room NICU setting. Use of high protein formulas or human milk was more used, but it was being fortified, and there was dedicated lactational consultants were available for NICU. And third one is the epoch, which consisted of 130 infants from July 2013 to June 6, 2016. Specific enteral feeding guidelines were instituted, and weekly reports on rounds of weight gain velocity, weight z-scores, and dietary intakes were plotted and assessed. And use of liquid protein to supplement the fortified human milk was done. The weekly reports increased standardized definitions of malnutrition that was entered in each patient's problem list. Here, the small for gestational age infants were defined as those with birth weight of less than 10 percentile. Appropriate and LGA infants were defined as those with birth weight of more than equal to 10 percentiles. And neonatal research network definitions were used to define the morbidities. The comprehensive predefined clinical and nutritional data was collected prospectively throughout the study period for all the extremely low birth weight infants. The collected data included maternal variables like age, antenatal steroids, hypertension, diabetes, mode of delivery, and multiple births. Infant characteristics like birth weight, sex, gestational age, Apgar score, size for gestational age. Data on the hospital course and morbidities for each infant, like use of surfactants, respiratory support, bronchopulmonary dysplasia, NEC, late onset sepsis, intraventricular hemorrhage grade 3 and 4, etc. And anthropometric data like birth weight, length, head circumference, body weight at Nadir, day 4, at first week, second, third, fourth, fifth, sixth, 8th, 10th and 12th week, and post-menstrual age 36 weeks and discharge. Statistical analysis, weight z-score at 8 weeks, 36 weeks post-menstrual age and discharge were compared with weight z-scores at 1 week of life. The outcome indicator here was taken as change in weight z-score between postnatal day 7 and 36 weeks post-menstrual age or discharge, whichever came sooner. Here, univariate and multivariate regression analysis was conducted. Weight gain velocity was conducted using the Patel exponential 2-point model. Appropriate statistical methods were used to analyze the data and its significance. The significance was defined as p-value of less than equal to 0.05. The results we will be discussing. The baseline characteristics like weight at birth, the epidemiological data of extremely low birth weight infants in all three epochs were similar. Thus, indirect outcomes could be compared. Here, the birth weight, the gestational age were almost constant. The univariate analysis showed that clinical characteristics and morbidities were similar across the three epochs. The table 2, this is a very important table where shows the infant's nutrition and growth by the three epochs adjusted to the covariates, unadjusted to the covariates. Although birth weight was similar, the weight at Nadir and at 1 week increased relative to baseline, and the days to regain birth weight decreased by epochs. Notably, significant decrease in time to sustain enteral nutrition and days of parental nutrition exposure were seen across the epochs. Additionally, weight and weight Z scores at 36 weeks post-menstrual age or discharge increased across the epochs, as did weight gain velocity and change in weight Z score between day 7 and 36 weeks or discharge. Next, we will discuss the trends in weight Z score by weeks. The trends of weight Z scores by week across epochs are graphically depicted in this figure. As compared to the previous slide, weight Z scores are more evident in the bar form. The red horizontal line in the middle represents the 50th percentiles, and the bottom red line represents the 10th percentile. In the epoch 1, the weight Z score graphs are crossing beyond the 10th percentile in the subsequent weeks. In epoch 2, the weight Z score graphs are just touching the 10th percentile, while in epoch 3, the weight Z scores are higher than the 10th percentile but less than the 50th percentile. The error bar represents the standard deviation. In the next table, we see that the adjusted multivariable regression analysis for the association of epochs with weight Z score changes from postnatal day 7 to 36 weeks. Here, 18 predictors were simultaneously entered into a multivariable regression analysis for change in weight Z scores between postnatal day 7 and 36 weeks post-menstrual age. And here the significant increase in weight Z score between day of 7 and 36 weeks post-menstrual age were observed across the three epochs, which accounted for 31%, that is p-value of less than 0.0001 of the variance. Now the positive predictors were 5 in number in this table, as per in this table, that is birth weight Z score, cesarean delivery, and each epoch. Negative predictors were gestational age, postnatal steroids, and increased days of parental nutrition. And not significant positive predictors were multiple birth, race, maternal age, sex, 5-minute Apgar score less than 6, NEC, IVH, and days to return to birth weight. Let's move to discussion. A strong improvement in the change of weight Z scores by 36 weeks compared with the day 7 indicates a meaningful impact of these practices. Prominent physiological water redistribution and diuresis of extracellular fluid occurs in extremely preterm infants in the first few days after birth. Z score target was more remote from birth, gave a more consistent baseline for comparison of infants across time. Thus, weight gain at 36 weeks was determined relative to the weight at day 7. Now, in epoch 1, we saw that family involvement was much less. It was an ICU-based setting, and maternal involvement was much less. Maybe this kind of setting is still existing in Indian scenario. But in epoch 2, the infants were receiving more of human milk, plus they were getting more maternal involvement in the form of like kangaroo mother care, skin to skin contact, breastfeeding, or even simple activities like bathing, diapering and holding the baby. In Epoch 3, which is the ideal situation, where earlier sustained enteral feeding, fewer days of parenteral nutrition, and increased protein and energy intake was incorporated. That is, the nutritional care bundle was instituted. So also in Epoch 2 and 3, there was enhanced support via registered dietitian. So the dietary advice could be manipulated, means they could be changed, and also there is lactational management units were in place. So now coming to the end, the strength of the study was, it was a large cohort of infants involving 584 infants. It was prospectively collected nutritional analytic data. There was minimal missing data, and it was a decade-long study from 2005 to 2016. The limitations of this article was a more expansion on the contents of the nutritional care bundle could have been incorporated in this article, and additional study is needed to determine which aspect of nutritional bundle had the greatest effect on the growth. Conclusion. We conclude by saying that implementation of nutrition care bundle was associated with improved weight gaining in extremely low birth weight infants. Now, what is the carry home message for us from this article? For my message to the practicing pediatricians would be, the Epoch 2 can be kind of situation, can be fully implemented all over India for improved weight gain for extremely preterm babies, even in rural areas where help from ASHAs and ANMs can be used. Kangaroo mother can be incorporated early and more efficiently. There can be initiation of early enteral feeding for improved weight gain. There will be early involvement of parents who maybe are in a better position with their higher qualification than our ANMs and ASHAs, and their better potential in handling the babies and learning the skills involved with the nurturing the baby may be very handy. And in Epoch 3, which can be fully implemented in higher centers and in medical colleges, where newer expertise facilities like laminar flow, ETOs facilities are available. Thank you.
Thank you, Dr. Kalpana, for a very nice and informative talk on the subject. May I now request Dr. Mohit Sahani, sir, to give some opinion on the article?
Yeah. Thanks a lot. Thank you very much. And thanks, madam. Madam has presented very nicely. And especially I like the messages she has extrapolated from the study as per the relevance for our Indian scenario. That is very nicely done. So I am very thankful, madam, for that. There are few other strengths, and first and foremost thing, and when we talk about the paper, so we talk whether it is a strong paper or a weak paper. It is not very strong because, as we know, it is not a randomized trial in this thing. This is a prospective cohort. They have collected, which is being assessed retrospectively. So that makes it okay kind of strength for this paper. But the good thing they have done in this paper is they have estimated this weight in different epochs, like 3 different groups, by Z-score. And it was quite intelligent by the researchers to have done that, because the thing is, they have done it over a very long time. And this is a confounding factor basically in this, because it started in 2005. In first 3 years, then 3 years. So actually the neonatal care advanced during that period of time. So there are many other confounding factors, because initially for those 3 first epoch, they took care of the babies in open care. So humidity must not have been maintained. So their weight gain would not have been as appropriate as that would have been in the third epoch, the third group. Because in Western world, because this is done in US, now all ELWs are taken care in closed incubators. So humidity is maintained. So that's why there are many other things which have been the confounding factors in these things. As madam rightly pointed out, the dietitian support came afterwards, and then more protein, better TP, and all those things were there. So those were the things but the message what madam has given is very clear. One, that level 3 units or level 2 units, whichever unit in periphery or in main centers, whatever nutrition policy for ELBWs we follow in the unit, it has to be as a package, nutrition package or a guideline. That guideline should be fixed, should not be person dependent, should be guideline dependent. And that has clearly shown the weight gain would have been appropriate. But these are the few major issues with this. Limitations has been talked about, but there are these are the other few limitations for these papers. And the other thing is, can I take this study and start implementing it in my practice? Yes, because in all the 3 epochs, what they have done, they have followed a structured guidelines of the unit, and therefore all the epochs have gained, the babies have gained weight, but in last epoch, the weight gain is better as compared to the other epochs because the conditions have improved and sports system has improved. Medical evidence studies have improved. So that's why that made the effect. And one of the exclusion criteria was the babies who have died. So maybe it must have been there that in epoch 1, the number of babies died would have been more, or the babies with a lesser gestation, 24-25 weeks with a lesser weight would have died more. So they have excluded that. So what you have included in the studies are all good babies. So there are a lot of confounding things, but yes, what we can adopt is what madam has given the final in the final slide. She has made inference out of it. That is very appropriately done, and I would like to thank her for that. Thank you very much.
Thank you so much, sir. Now I would like to invite Raigad IIP Vice President, Dr. Vikas More, to introduce our second expert, Dr. Vibhor Borkar, and also introduce our second speaker, Dr. Remanka. Over to you, sir.
Thank you. Yeah, thank you so much, Dr. Swati. I welcome all of you for this unique initiative.
Dr. Vikas, please increase your volume.
I'm really sorry, there's a lot of noise around. There is some separation. So I'm really thankful everyone for joining this session. We are very much blessed to have Dr. Vibhor Borkar, who has done his graduation from KEM and done his PG from PGI Chandigarh, has done his fellowship and DM from SDPGI Lucknow. So he's an excellent academician, and we are very much blessed to have today to have him on this to guide us on this topic. And I'm also thankful to Dr. Remcha Kalbhatkar from Goa Medical College. She will be presenting a case on a clinical scenario of acute viral hepatitis in children due to unknown cause. Over to you, Dr. Remcha.
Dr. Neha, please start slide sharing. Welcome, Dr. Remanka.
Thank you, ma'am. I'm Dr. Remanka Kalgatkar, and I'm really thankful to the team to have given me this opportunity to be a part of the journal club. Today, I will be discussing with you all an article which is titled as The Clinical Spectrum of Children with Acute Hepatitis of Unknown Cause. This article was published in the New England Journal of Medicine on August 18, 2022. The impact factor of this journal is 91.245. This article, the study was conducted in the liver unit of Birmingham Women's and Children's Foundation Trust, which is situated in the United Kingdom. Next slide, please. So, viral hepatitis, as we all know, is a systemic infection affecting predominantly with primary inflammation of the liver by one of the 5 known hepatotropic viruses. And 70 to 80% of the cases are seen to occur in children are due to hepatitis A virus. There are a few non-hepatotropic viruses also that can rarely cause viral hepatitis in children. Some to name are cytomegalovirus, Epstein-Barr virus, herpes simplex virus, adenovirus. And most of these cases in the young, even in India, are asymptomatic or mild jaundice, and they are seen to resolve without any specific treatment. Now, this article report is done in view of an unprecedented outbreak of viral hepatitis in children of unknown cause, which was seen in the United Kingdom from January to May 2022. This outbreak was seen in the absence of any change in the environmental condition or any change in the living condition. Next slide. So the aims and objectives of this study are: one, to find the causal agent of acute hepatitis in children other than the usual hepatotropic viruses; two, to find out the variation in the clinical presentation; to evaluate the variation in the biochemical presentation; and to find out the course of illness and early outcome of viral hepatitis of unknown cause in children. Next slide. So coming to the method, this study was conducted in a retrospective way, which is because of the fact that it was based on an unprecedented rise of cases seen during the said period. So one had to go back in time to understand the clinical spectrum of these cases. It included children referred to a single pediatric liver transplant center in the United Kingdom, and the data collected was from the National On-Call Reference System records and inpatient notes. The inclusion criteria here was children who are less than or equal to 10 years, refers to the unit between January 1st to April 11, 2022. The confirmed case definition of the United Kingdom Health Security Agency here was acute hepatitis, which was not due to hepatitis A to hepatitis E viruses, or due to any metabolic, inherited, congenital, mechanical causes, and with a rise in serum aminotransferase levels more than 500 international units per liter. Next slide. The acute liver failure definition taken for the study was coagulopathy not corrected with vitamin K, with a prothrombin time of more than 15 seconds and an INR of more than 1.5 with encephalopathy, or a prothrombin time more than 20 and an INR of more than 2 with or without encephalopathy. The investigations included here were a complete blood count, liver function test, coagulation screening, viral serological tests and molecular tests for some viruses, abdominal ultrasound, liver histology, which was taken from either biopsy samples or the explanted livers, and some other tests which were not done for everyone but on case-to-case basis included serum ferritin, serum alpha antitrypsin, celiac screening, autoantibodies, and serum paracetamol levels. Now here we should know that these tests are done only in selected patients wherever applicable. Also, the liver biopsy done here was only for academic and the study purpose and not done normally. Next slide. The acute liver failure protocol, which was used here, was IV broad spectrum antibiotics, antifungal, vitamin K, 70% maintenance fluid. Those who didn't have liver failure received supportive care, and oral fat soluble vitamins, that is vitamin A, D, E, and K, and also deoxycholic acid. And those with acute liver failure were included in the super urgent category 6 for liver transplant, and tenofovir was administered as antiviral treatment after transplant. And viral loads of adenovirus were monitored with PCR subsequently. The clinical outcomes recorded were in 3 categories. 1 was improving condition, 2 was those who underwent liver transplant, and 3 was death. Improving conditions here was defined as resolving liver dysfunction with consistent decrease in bilirubin and serum aminotransferase levels with normal coagulation. Next slide. Now coming to the results. As mentioned earlier in the introduction, most of the cases of viral hepatitis in children are asymptomatic or mild, and they resolve spontaneously. Symptomatic hepatitis is seen to occur in around 30% of infected children. In this study, we see that around 93% of children had presented with jaundice and 54% with vomiting. In our country, not all cases present with jaundice. Also, 30% cases had presented with diarrhea or pale stools or abdominal pain. Usually, diarrhea is not seen to occur in cases of viral hepatitis. Now here, the finding of vomiting plus diarrhea in around 30% of the cases gives us a clue that the agent here is not the usual hepatotropic virus, and it raises a suspicion towards some non-hepatotropic virus. Also, the pale stools is not seen in most cases, unless there is cholestasis. Another striking feature which we see in this table is that fever was present only in about 9% of the cases. So in our setting, we need to be vigilant about if there is any antigenic variation or immunological variation which is occurring in the known hepatotropic viruses. Coming to the next table down, the clinical examination findings. However, the findings here were there only for 34 of the children included in the cohort. Our total cohort was 44. So clinical interest was found here in 24 of the 34 patients, that accounts for about 70%. And hepatomegaly was seen to be occurring in 18 cases, that is around 52%. The abdominal ultrasound findings, which I have marked in green box, they showed gallbladder thickening in 45% of the cases and hepatomegaly in 27% of the cases. Also, mild hepatomegaly and abdominal lymphadenopathy was found in 14 to 18% of the cases. Now, this presentation looks like more of viral infection because usually viruses affect the lymphoreticular system. So patients will have some mild hepatosplenomegaly, can have some mild abdominal mesenteric lymphadenopathy. Next slide. Now coming to the demographic and biochemical characteristics. The table actually divides into three parts: total cohort, children who did not undergo transplantation, and children who underwent transplantation. If you see the first part of the total cohort, we see that the median age range was around 1 to 7 years with no gender predilection. The white blood cell count was within normal limits in the total cohort. However, keep in mind here that the data of WBC count was missing for 12 patients out of 44 patients. Also, the serum bilirubin level and the serum aminotransferase levels here were found to be raised in the entire cohort, and the peak bilirubin level was seen to occur at a median of 5 days from the onset of jaundice, and the peak serum aminotransferase levels were found to occur at a median of 3 days from the onset of jaundice. Also, the synthetic function of the liver was seen to be affected. This was evidenced by the reduction of serum albumin levels and prolongation of prothrombin time in the entire cohort. A prothrombin time of more than 15 seconds was seen to occur at around 2.5 days in 16 children, and a prothrombin time of more than 20 seconds was seen to occur at a median of 7 days from the onset of jaundice in the transplant group. Next slide. Now we come to the most important part of the results. This slide shows us the pathogen tests which were done in this study. Here we can see that 93% of the cases who were tested for human adenovirus by whole blood PCR were positive for the same. Usually, we see that adenovirus is not known to cause hepatitis. However, it mostly causes respiratory illnesses or conjunctivitis, gastroenteritis, or hemorrhagic cystitis. Adenovirus, though in literature, is known to be one of the rare causal agents of viral hepatitis, but the incidence of the same is still not known. So, a 93% testing positive here was a huge number. Another striking feature here noted in the slide is after adenovirus, the second highest positivity rate is seen for enterovirus, which is around 56%, which is again not a known causative agent for viral hepatitis. Note that all these viral pathogen tests are usually not done in hepatitis cases. Here, we are just doing it for the study purpose, as we are trying to find the causal agent in this study. Next slide. This slide is just a summary of the confirmed cases and the outcome of acute hepatitis, wherein out of the total 44 children included in the cohort, 30 were tested for human adenovirus by PCR, out of which 27 were positive for the same. 22 survived with native liver, however, 5 required liver transplantation. And on the other side, 14 of them who were not tested for human adenovirus by PCR, 13 survived with native liver, whereas one had to undergo liver transplant. Next slide. Subsequently, in the study, it was seen that 86% had undergone spontaneous improvement and 14% developed acute liver failure and subsequently had required liver transplant. If we look at the table on the right-hand side, it depicts the total number of hospital admissions for acute hepatitis of unknown cause over the last 10 years. Now here we see that there is a rising trend seen in the total number of hospital admissions. This is depicted in the light blue color bar. Also, the number of patients requiring liver transplant post-acute liver failure was found to be on the rising trend. This is shown in orange bars. Now, please note here that for the year 2022, the liver transplant number is only for the period of Jan to April. That is, for the other 9 years, it is for the entire year. So we see that the trend of rising transplant requirement is actually high in 2022. Now, 5 out of the 6 patients who had acute liver failure had rapid progressive encephalopathy. Interval from onset of jaundice to encephalopathy was around 6 to 7 days. However, a good thing here was from the listing of transplant to the actual transplant, the average time was around 2 days. 4 out of the 5 with human adenovirus viremia after transplant had received Tirocovis until the viral load was less than 500 copies per ml. And the duration taken for reduction of the viral load to less than 500 was a median of 8 days. None of them had received glucocorticoids or any immunomodulating agent. Also, on an immunohistochemical test for human adenovirus were negative. However, the results for adenovirus PCR assays targeting the hexogene of adenovirus were positive in 3 out of 6 exons. The nucleotide sequencing suggested similarity to human adenovirus serotype 41F. Next slide. Now coming to the discussion, most of the cases in the cohort were previously well, and most of the cases of hepatitis resolved spontaneously, but a high percentage of hepatic failure warranting transplant was seen. Although the investigation for a causative agent is ongoing, the result of biochemical tests, USG findings of thickened gallbladder wall with pericholecytic fluid and hepatosplenomegaly were consistent with a possible viral cause here. The extensive viral testing also had identified adenovirus as the most common pathogen, primarily the subtype 41F. Now, this 41F subtype of adenovirus is primarily seen to cause gastrointestinal problems. And this could now explain us why in the clinical presentation, around 30% of the children had actually presented with vomiting and diarrhea, which is not usual with the normal hepatotropic viruses. Nevertheless, the liver histologic findings were negative for viral infusion bodies or immunostatin. So a working hypothesis was established that an abnormal host response, possibly because of lack of exposure amidst the COVID-19 lockdown, caused an epidemic of adenovirus, causing complications to manifest most frequently. Also, it could be due to the enhanced laboratory testing of adenovirus that an existing rare outcome is now being recognized due to increased testing. On the right-hand side, I have boxed two studies which also gave a positive result for adenovirus in acute hepatitis. One was a British pediatric surveillance unit, which was conducted as a 13-month-old study from January 2014 and had shown 6% of the children to be positive for adenovirus. And in the second box, we have a study conducted in Alabama in United States from October 2021 to February 2022. Here, 9 children had acute hepatitis and they were found to be positive for human adenovirus. 3 of them had liver failure and 1 had required transplant. Next slide. So The presenting and the peak bilirubin and serum aminotransferase levels, the prothrombin time, and the adenovirus load on PCR were seen to be higher among the transplant candidates. Also, a decreasing adenovirus load was seen after transplant with or without pseudocovid. However, the time required to reach a viral load of less than 500 copies per ml was seen to be longer in that child who had not received pseudocovid. Follow-up results showed normalization of liver biochemical tests at around 4 to 8 weeks after the first hospital presentation. But this data was available for only 11 out of the 44 children included in the cohort. The limitations of the study, one was it was a small cohort of patients which was evaluated retrospectively, so which precludes the meaningful statistical comparison. And second, some of the data were missing, like some data in the, some children's clinical features were not there. Some children had not undergone clinical examination, or the data of clinical examination was not found. So this is expected as the study was done retrospectively, as there was a sudden outbreak of cases. Next slide, please. So the scope of improvement here, first, increasing the sample size would have improved the understanding of the natural history and immunopathogenesis of this illness. Metagenomics and immunological investigations of the host would have helped to understand hepatotropism, and an aim to fill up the gaps and get complete data would have helped for better analysis. Next slide. So what do we learn from this study? So the message that I would like to give to our pediatricians in India, that newer emerging and re-emerging agents are seen to come up whose spectrum of clinical presentation outcome is still to be understood. HIV, H1N1, COVID-19 viruses are a few of the emerging viruses, and they come up with multi-system involvement. Also, re-emergence of the known viruses with more virulent strains should be kept in mind. And clinicians need to be vigilant about children presenting with prodromal illnesses with early referrals to higher or tertiary care for early management. So I would like to end with the phrase that what the brain doesn't know, the eyes don't see. Thank you.
Nice presentation.
Very nice presentation, Dr. Remanka. Now I request Dr. Vibhor Borkar sir to comment on the article.
Yeah. Hello. Hello.
Audible. Audible.
Yeah. Am I audible?
Yes.
Yes. Yeah. Hey, very nicely presented, well in depth, and whatever has been there mentioned in the article, all the relevant points has been told or been presented by Dr. Remanka. Can you please start your video, Dr. Remanka, so it will be a good to have an interaction. Yeah, hi. So I think, yeah, and apart from all the article details, also the important is a clinical implication for Indian scenario has been mentioned. Now about this article, this is basically has been brought out from an epidemic situation. So, and this is something, whatever they have presented the data, which is beyond the usually means they routinely use protocol. So that's why there will be a lot of heterozygosity in the data collection and all. So this will be a limitation of any statistic, any data which is provided when they have done in an epidemic situation. So as rightly said, that this is a very small cohort, and the comparison, statistical comparison, is really not possible. So you say though. So here, as a as a clinician, what I will see it as a paper. Okay, there is a one group of unknown etiology which is coming up in a certain geographical area. Whether same conditions are there in my country or not, that I'm not sure. But yes, we do see a different unknown etiologies where our workup is negative. Commonly workup, the cases that we work up are all viral illnesses, along with the medication history also. in the probably the definition of the cases, they have not mentioned the medication history. Only paracetamol they have mentioned, but in our scenario, there are all other medications, other alternative pathy medications are also used. So that also we should use. Now, when we have ruled out common etiologies, we do workup for the other etiologies by doing a biofire from the blood and look for these viruses. And adenovirus is a part of that panel, so it can be done in India. So apart from adenovirus, so we do EBV, CMV, adeno, herpes virus, simplex 1, 2, 6, 7, chickenpox, parvovirus, and enteroviruses. These are routinely seen, and within probably at 24 hours, we can get the result that is applicable for the cities like Mumbai and the other outskirts. What the extra time will be the logistic in the sending the samples. So this is doable, but of course we will be having the limitation in finding the which kind of subtype of the particular virus it is, and it is really it's causing or not. But till now, whatever the cases we get of an unknown etiology, we have not found adenovirus, at least in my clinical practice. I am not sure what is the experience of the other eminent members in this panel. Other thing, probably what I will like to know as a clinician here is, so you have this group of like the 6 children actually who presented and then went up to a stage of where they required a liver transplant. At the same time, if you see the graph of the admission, out of the 44, only 14 required admission. So there were a good number, almost around 30 patients who were still included as an acute viral hepatitis, but they're managed on the OPD basis. That's the reason probably they didn't have the clinical details of this patient. So out of this 14, so few have, or 6 have required a liver transplant and few improved. So can I get this? So now if you try to compare 6 patients versus 30 other remaining 39, the comparison may be very skewed because they are not the comparable ones. But if we take this 14 patient and they present the data, okay, the 14 patients were there where they required admission. Now, can I compare the clinical data? Of course, these even one number and here there will change the percentage like anything. But I like to know, are there early predictors where I can see which child is going to get deteriorated, which child is not going to get deteriorated? Almost here they have said that a rapid worsening of encephalopathy. Yes. Then in this scenario, can I use pseudofluid? Because see, I can get an adenovirus PCR in a 1 day time, and in 5 days time is going for this child to progress to an encephalopathy. So any suggestion from the authors about a pseudofluid use when they have not gone to a liver transplant stage? That is something probably I will like to see at this paper. I think rest of the things are the limitations that will be inherent. I don't think the authors can sort it out. That is, I think, the relevant point. I think I can take this from.
Thank you so much, sir, for the comments. And now I request Dr. Jay Bhandarkar, sir, to take up few questions from the chat box if there are any. Over to you, sir.
Hello. Hello.
It's audible, sir.
I'm on the road. Can you take the question from the chat box? It will be better.
Sir, I am having one question that Dr. Bihor, can we suspect clinically that this person may worsen and the early referral is required in that? You can tell us about key points of clinical examination only.
Okay, so a clinical examination wise, when a child or patient has an acute viral hepatitis, most important thing is it icteric or not? Most of the time before going to a failure, they'll have icteric. So we'll have a non-icteric, we can manage, and we have a good safety period. If you are getting an icteric hepatitis, that is the first stage towards probably a liver dysfunction, not failure. It is very significant liver dysfunction. Second thing I will see about what is the mentation status of the child. Is the child is drowsy? So there will be a grade 1, grade 2, grade 3. The challenge to a pediatrician is to pick up a child in the grade 1 encephalopathy, because all the kids will be irritable. A grade 1 encephalopathy is also irritable, and I am approaching a child for any cannulation, sister approaching a child for IV fluid, again the child will be irritable. So it's very important to early pick up this irritability from the environmental irritability due to the environment. So that only probably when we are away from the parent, the mother can tell when nobody is around, is the child is her usual self, is child sleeping a lot, if child is unusually irritable. So younger the child, this is more a clinically difficult challenge. That is the second point. Third point will be what's happening to the liver span. Is the liver span contracting? Now, as Dr. Rimaika has mentioned that their ultrasound finally the hepatosplenomegaly was there. So this splenomegaly is a radiological splenomegaly that is different from what we get clinically. Most of there will be a some amount of splenomegaly. Even in acute viral hepatitis also, you can get a tip of spleen, and that doesn't take us away from a acute viral hepatitis. Spleen, presence of spleen doesn't mean it is a CAD. So if you are getting a contracting liver span, yes, that is an again early indicator that probably we are going towards the liver failure.
Thank you, sir. Now I request our guide, respected Mohanty sir, to give his comments.
Good evening, everyone. I am so happy today. Both the speakers have done very, very well. This was discussed with them twice, and they have done justice to the topic and covered all the aspects. And our experts are the genius in the branch. I have nothing more to add. I hope we should continue this in a greater spirit and homework like these two young pediatricians have done. The selection of the topics early and early discussion will go a long way to help in perfecting the presentation as it has happened today. I think we have reached a milestone today. I am very, very contented and happy today. Thank you. And nothing else to add.
Thank you so much, sir. Now, as we come to the end of today's journal journey, I request Dr. Chitra Madam to present vote of thanks.
I could see Dr. Dhananjay Rajput, Secretary, Raigad IAP. If he can give vote of thanks, it will be very nice. Dr. Dhananjay. Okay. I think, yeah, he has not unmute also. So we are very thankful, Maha IAP team. We are having galaxy of the invited guests today. Thank you, Dr. Basavaraja sir. Thank you, Dr. Harish Pemde sir. Thank you, Dr. Jayant Joshi sir. Our experts for today's journal journey, Dr. Mohit Sani and Dr. Vibhor Borkar. Also, the convener, Dr. Jay Kumar Bhandarkar, Secretary, Dr. Amol Pawar, our inspiration, Dr. Hemant Gangolia sir, and guide, Dr. Nimen Mohanty sir. Backbone of the program, Dr. Neha Singh and Pallavi madam. And thank you all the attendees. We are now ending the session. Thank you very much.
Before we would like to thank moderators, Dr. Swati Likite for our first appearance. Excellent work done by madam, and as well as Dr. Chitra Kulkarni madam leading this way of moderating session from one episode, from first episode. Thank you very much, both moderators.
Don't forget Dr. Raut, Dr. Vishal.
And
yes.
Dr. Vishal, of course, the techno wizard of our this thing. Yes.
Thank you, sir. Mrs. Pallavi, please stop the sharing.
Yes, ma'am.